Mogadishu, the capital of Somalia. At the end of December, 2 members of Médecins Sans Frontières, Philippe and Andreas, who everybody called Kache, were killed in one of Mogadishu's hospitals. Dadaab, Somali refugee camps in the north of Kenya. 2 female MSF staff members were kidnapped here. Blanca and Montserrat went missing 3 months ago. In the face of these 2 acts of aggression against its staff, MSF finds itself in a dilemma: how to assure the security of its teams in Somalia, where emergency medical relief helps to save tens of thousands of lives. MSF has asked the Somali authorities and the people controlling the areas where Blanca and Montserrat are being held to do their utmost to facilitate their release and to guarantee the security of humanitarian aid workers so that the population can continue to receive the care it so desperately needs. The sudden influx of over 20,000 people in Doro caused a medical emergency, but also led to problems of hygiene and access to water. MSF decided to intervene at the end of November to install latrines and pumps and to treat cases of diarrhea, malaria, and respiratory infections.
Our journey from Sali was very difficult. We were very tired from carrying things on our heads and our children on our backs. In October, it rained on us while we were walking.
The presence of these refugees also brings its own security issues. Tension is mounting with the locals from Doro, who now find themselves struggling to have access to water. Still in South Sudan, intercommunal violence in Jonglei state has forced thousands of families to flee. MSF evacuated the area temporarily after 2 of its facilities were ransacked. The team returned at the beginning of January. Many people still hiding in the bush have absolutely no access to health care. To improve its tuberculosis program, the MSF team in Kampong Cham has introduced a new and faster diagnostic test. The team has also set up a comprehensive follow-up system, home-based care services, and proactive detection targeting the people in contact with patients.
It's like a network going through the patient's network of close contacts to try and ascertain who might have been exposed, who might be at high risk of disease, or who might already be showing symptoms of disease, and getting them to come to the clinic so we can follow them up and do our tests on them to see whether they might have TB or not.
This system enables MSF to increase detection and to turn back the tide of the spread of the disease. The challenge for the team is also to communicate as much as possible with the population. By holding awareness-raising seminars in mosques, pagodas, universities, and participating in radio programs, they hope to increase understanding of the disease and its symptoms and reduce the stigma faced by patients. To diagnose and treat malaria cases as swiftly as possible, access to treatment needs to move beyond the hospital and into the villages. For those who live too far from a healthcare center, the first contact will be the malaria village worker.
The malaria village workers are chosen by the community and then trained by MSF to screen patients for malaria, to give the first dose of treatment, and to assess the severity of each case.
Any complicated cases are referred to the health centers, and children who are very weak are transferred by motorbike to Moisala Hospital. This program, now in its 2nd year, has led to a reduction in cases of severe malaria. 33,000 children in all have received treatment. The team, however, wants to go further and is planning to introduce preventive treatment for children under 5 and for pregnant women during the malaria season next year. Children who come to Rutshuru Hospital usually have malaria. Very weak, they need to be treated quickly. The malaria season began in September, but since November, the doctors have observed an extremely high number of patients. The pediatric unit is working flat out, and children are often several to a bed.
Most of the children treated here have malaria. As they have low hemoglobin levels, 2 or 4 grams, they need a blood transfusion.
Malnutrition is the second most common illness here. Children often live far from the hospital and delay coming for treatment. To limit this delay, MSF supports 4 healthcare centres in the outlying districts, like this one in Tamugenga. The MSF team in Tabar is in the middle of construction work and will soon see the opening of a new 120-bed hospital. But access to healthcare is still sorely lacking. Already too scarce before the earthquake, facilities are still too distant or too costly for the people living in the slums. But the population's health and hygiene needs are still immense. The cholera epidemic that started at the end of October 2010 continues to reap its toll.
When I arrived, they put me on a drip. I couldn't stand up, I couldn't speak. The pain tore me apart. I can talk now, and I'm getting my strength back. I feel like new.
During the epidemic, MSF treated 1/3 of the cholera patients in the country. Its teams continue to treat new cases and to monitor the evolution of the disease in order to be ready in the event of a new peak of cases. In the area affected by the earthquake, the organization is running 4 hospitals specialized in emergency surgery.